Morning, everyone. Now I'm going to present a series of cases. Case number one, 29 years old Mrs. B with G4P2L2A1 with 31 weeks of gestation with a known case of rheumatic heart disease came for regular review. On examination, she had regular pulse rate with a pulse rate of 78 per minute, and on CVS examination reveals pansystolic murmur and mid-diastolic murmur over mitral area and loud S2 over the pulmonary area. She is on injection Clexane, metoprolol, and Lasix. Now, what is your next step of management here? In case 2, 29 years old Mrs. C, G2A1 with 12 plus 2 weeks of gestational age with known case of rheumatic heart disease has undergone mitral valvotomy done twice in 2015 and 2019, presented with the complaints of breathlessness on exertion, which is of NIGA grade 1. She was found to have all regular pulse with a pulse rate of 70 per minute and mid-diastolic murmur over the mitral area, and she is also on metoprolol, Lasix, and penicillin injection. Echo showed severe mitral stenosis with the mitral valve area is 1.626 centimeter square with the ejection fraction of 58%. What is the next line of management here? In case 3, Mrs. A, 25 years old, primary gravida at 12 plus 1 weeks of gestational age with a known case of double valve replacement secondary to the rheumatic heart disease and gestational diabetes mellitus on medical nutrition therapy came for review to OPD, and on examination she has irregular pulse with a pulse rate of 120 per minute and click here to over the mitral and aortic valve. She is also already on injection heparin, diltiazem, aspirin, and metoprolol. What is your next line of management? Okay, before proceeding with our case, I need to highlight on approach to RHD management in pregnancy. There are 4 steps in RHD management in pregnancy. Step number one is maintain high index of suspicion. Step number 2, preconception counseling and risk stratification. Step number 3, lesion specific diagnostic consideration and therapeutic option. Step number 4 is delivery and postpartum period. So now come to step number 1, high index of suspicions. In India, RHD continues to be a significant cause of cardiovascular morbidity and mortality among children, adolescents, and young adults. And in a recent Indian study, proved that 26% of the women were diagnosed with RHD during pregnancy, and many of the maternal deaths occurred in those who previously undiagnosed. So it indicates that RHD is more common in the women of childbearing age, but the RHD is more commonly diagnosed during pregnancy, and many pregnant patients are not aware of the RHD prior to pregnancy. So this is a 2 study. One study in Sub-Saharan Africa reported that the prevalence of RHD is more than 20 per thousand, and another study in Uganda reported that 15 by 1000 pregnant patients had RHD, but among this, less than 5% only being aware of cardiac diagnosis before pregnancy. So this is the indication we should have a high index of suspicion of rheumatic heart disease during pregnancy, because many of the maternal death occur in those who previously undiagnosed. And step number 2, preconception counseling. So as per 2018 ESC guidelines, recommended that asymptomatic women with a moderate or severe mitral stenosis or severe symptomatic aortic stenosis should avoid pregnancy and undergo pre-pregnancy intervention and then plan for pregnancy. So this is a study why we should undergo pre-pregnancy intervention. This is a study done in 21 pregnant patient who has undergone cardiothoracic surgery during pregnancy period from 1976 to 2009. And from these patients, maternal and neonatal outcome reviewed. Of the 21 pregnant patients, 14 pregnant women who delivered after surgery, there were 3 fetal losses, 3 preterm deliveries, and 7 term infant, and 1 patient lost to follow-up. So this study also indicates that the maternal risk not increases for cardiothoracic surgery performing during the pregnancy. Only the fetal and the neonatal mortality increases if you perform cardiothoracic surgery during pregnancy. So this is why ESI guidelines recommended that pre-pregnancy intervention and plan for pregnancy later for heart diseases in pregnancy. So the other things is that the surgery prior to pregnancy decreases the pregnancy risk, mainly decreases the fetal risk, and enable the mother to better tolerate the physiological changes of pregnancy, and also it provide a long-term benefit to the subsequent health of mother and child. If the woman presents early in pregnancy with severe valvular disease, does not undergo any surgery prior, then you recommend termination of the pregnancy. If the mother declines termination of pregnancy, then in case of intractable symptoms, we can plan for surgery. But the best thing is you can safely delay the surgery until the fetus viable. The fetus become attains the viability, then you deliver the baby and plan for interventions immediately after the delivery of the baby. So the interventions you are valve replacement and valve repair. Valve replacements are two types: mechanical prosthetic valve and bioprosthetic valve replacement. The main drawback of mechanical prosthetic valve is they require anticoagulation, mainly warfarin, because warfarin is effective in preventing the thrombosis related to the mechanical valve. But the risk is warfarin causes embryopathy to the fetus. But when we start the mechanical prosthetic valve patients on heparin, then the fetal risk may not be there, but there is an associated increased risk of thromboembolic complications. And so the mechanical prosthetic valve associated, it requires anticoagulation. And then the next type of valve replacement is bioprosthetic valve replacement. With this pregnancy tolerate well, but it deteriorates rapidly and it requires reoperations. And valve repair, because of these two drawbacks, like a bioprosthetic valve repairment deteriorate rapidly, and a mechanical prosthetic valve requires warfarin anticoagulation forever. So because of these two drawbacks, for those women who are planning for pregnancy, we will prefer valve repair, balloon valvotomy for stenotic lesions, and valve repair for regurgitation lesions. And then we have to do strict risk stratifications. There are many maternal and fetal cardiac risk predictors out there, but what we are following is modified NIGA classifications. Modified NIGA classifications are, there are four classes: WHO 1, 2, 3, 4. In WHO 4, pregnancy is not recommended. For the WHO class 4s are pulmonary arterial hypertension, severe systemic ventricular dysfunction, moderate systemic right ventricular dysfunction, severe mitral stenosis, severe symptomatic aortic stenosis, severe aortic dilatation, severe coarctation. So these patient pregnancy is absolutely contraindicated. In WHO class 1 and class 2, in class 1, once or twice follow-up in local hospital is advisable. But in class 2 and class 3, the expect hospital follow-up is advisable. The step number 3 is lesion-specific diagnostic consideration and therapeutic options. So if our pregnant patient has mitral stenosis, usually if the patient has modified, if comes under modified WHO class 4, then counsel for termination of the pregnancy. The patient, if the pregnancy continues, then try to do symptomatic medical treatment as much as possible. The mainstay of the most common complication we can expect during pregnancy is heart failure and atrial fibrillation and other arrhythmias. So heart failure, the mainstay of treatment in pregnancy is also beta blocker. The patient develop pulmonary edema, treated with diuretics. If not controlling within, you can add on digoxin. If the patient develops atrial fibrillation, then you can consider anticoagulations and try to do medical management. If the medical management is also fails, then assess for surgical interventions, but to keep the surgery as a last resort for all the lesions, for all type of valvular lesions. So in mitral stenosis, the most commonly they are more prone to atrial fibrillation, heart failure. We have to treat that. In aortic stenosis, usually bed rest and diuretics sometimes needed. The ongoing symptoms are there, then we can plan for balloon valvuloplasty in aortic stenosis. In mitral regurgitation and aortic regurgitations, usually the regurgitation lesions are less severe in pregnancy. Usually the regurgitation lesions are less well tolerated than stenotic lesions. So many regurgitation lesions does not require intervention during pregnancy. Any acute heart failure, if the patient has acute heart failure in pregnancy, the fetus is not viable, try to deliver the baby and treat for heart failure. The fetus is viable and the mother wants to continue the baby, then pregnancy should be continued, and you should monitor the mother and fetus status and tailor the heart failure therapy. And the anticoagulations in pregnancy, the indications of anticoagulation in pregnancy are atrial fibrillation or any left atrium thrombus or enlarged left atrium, severe mitral stenosis. These are the indications of anticoagulation in pregnancy. In first trimester, according to ACC and the AHA guideline, warfarin less than 5 mg per day is advisable. Heparin or a low molecular weight heparin or unfractuated heparin. In second and third trimester, warfarin plus daily aspirin till 36 weeks of gestation. After 36 weeks, change the warfarin to dose unfractionated heparin. The patient is on prosthetic valve who became pregnant. In that time, what we have to do is, first the patient, we have to say patient is on low dose warfarin, high dose warfarin. Low dose warfarin means warfarin less than 5 mg per day. High dose warfarin is warfarin more than 5 mg per day. So the patient is on low dose warfarin 5 mg per day in first trimester. Then our guidelines is to continue the less than 5 mg warfarin dose. So continue is the 2A recommendations. And in second and third trimester also continue the low dose warfarin. And during the 36 weeks of gestation, change that to unfractionated heparin. And to 4 to 6 hours before delivery, stop unfractionated heparin and restart for unfractionated heparin 4 to 6 hours after delivery. The patient is on high dose warfarin, that is warfarin dosage more than, she requires warfarin more than 5 mg per day. In that time, the 2A recommendation is hospital change to, better to change to low molecular weight heparin. And then in second and third trimester, again change the low molecular weight heparin to warfarin. And in 36 weeks, the same things happen. Again, warfarin change to unfractionated heparin, and 4 to 6 hours before delivery, stop and restart the restart the heparin 4 to 6 hours after delivery. So during delivery and postpartum period, termination of the pregnancy plan should plan after even after the fetus attains viability, should plan immediately. And the mode of delivery usually prefers vaginal delivery with cut shortage of the second stage of the labor. And LSC is indicated in dilated aortic root more than 4 centimeter, acute severe congestive heart failure, recent myocardial infarction, severe symptomatic aortic stenosis, warfarin administration within 2 weeks of delivery, or any need for emergency valve replacement immediately after surgery. And in peripartum period, observe for 72 hours for the development of any pulmonary edema or heart failure features and treat accordingly. The endocarditis prophylaxis, usually in vaginal delivery, only if the severe stenotic lesions or the patients have some other concurrent infections, then we need to give endocarditis any antibiotic prophylaxis. But for cesareans who are delivering by cesarean mode, in those antibiotics will give prior to surgery, will same provide protection against the endocarditis as well. So in our patients, now anyone want to make diagnosis of these 3 cases? Now a patient is in 32 weeks of gestation. Patient has not undergone any surgery prior. She is on an anticoagulation also. Rheumatic heart disease, mitral stenosis. Now, what is your next advice here? So in this patient, already it's a G4, it's a high risk pregnancy. And then we have to plan termination of pregnancy because the fetus attains viability. If in this patient, in our patient, we have planned for termination of pregnancy and mitral valve replacement immediately after termination. Case number 2. This patient already has undergone mitral valvulotomy, has undergone intervention, surgical interventions. Now she is presented with the symptom of a NIGA grade 1 breathing difficulty. Now, what is your next line of management here? So here, because echo also showed severe mitral stenosis, we will advise only the termination of pregnancy. The patient, the mother wants to continue the pregnancy, then we have to treat it symptomatically and try to delay the surgery till the viability attains. If you become intractable, then we have to perform surgery during second trimester. If we can manage with the symptomatic treatments, then we can delay the surgery till viability. Then we will deliver, and then after delivery we will plan for surgery. Then case number 3. This patient has an on mechanical valve, double valve replacement. Mechanical valve, now she is in the 12th week of gestation. Now, just now she crossed the 12th week of gestation. What is your, now she is on injection heparin anticoagulation. Now, what is your next line of management here? Yes, warfarin, because we know that mechanical valve, high risk of thrombosis. Warfarin only helps in effectively preventing the thrombosis rather than heparin. And she is also entered the second trimester of pregnancy. Now we can safely shift the heparin to warfarin here. So these are my 3 cases. So in case 1, termination of pregnancy as pregnancy crossed the period of viability. In case 2, advised termination of pregnancy, and if the mother wants or if the symptom persists, plan for a valve replacement during second trimester, or observe the pregnancy till the period of viability and deliver, and then plan for surgery after delivery. In case 3, because it's a mechanical valve to prevent the thromboembolic risk, and patient also reaches second trimester, we will change the heparin to warfarin. So my learning points are approach to RHD in pregnancy, importance of pre-pregnancy intervention and counseling. And if you save the heart with proper intervention prior to pregnancy, it will save the soul in the future. Thank you.
Thank you. Any questions or comments?
First case 1, we are termination of pregnancy. Then if we are doing termination for every cases, then which cases we are continuing? Majority of cases we are continuing until unless they are going into full-blown failure or severe mitral stenosis.
But here she is a G4, or echo is also very bad. She also had pulmonary hypertension.
Building on that, maybe transit change, or maybe I have misunderstood. It seemed like the term termination of pregnancy was used synonymously with liquor. And pardon me? Am I wrong? The term termination of pregnancy is used synonymously also with delivery. Because planned delivery, and maybe plans have changed, but it seems like, at least from my training, if you're planning on delivery and hoping for a viable baby, you don't call it termination of pregnancy. You call it delivery. And so maybe if the times have changed, then I need to catch up. But otherwise, I think it's confusing to talk about termination of pregnancy in the second, third trimester when the mom is intending to keep the pregnancy.
At later, I'm not the expert, of course, but I think it's like when the pregnancy becomes, puts the mother's life at risk, when the pregnancy has to end, even if it's a little early for the baby. So they terminate pregnancy in the sense that, like the way that for preeclampsia, the treatment is the pregnancy has to end, the woman has to deliver. And if the fetus, we also hope at 32 weeks that the fetus is viable, but even though it's higher risk for the child, and it will be better for the baby, the child might live longer if, or the odds for the child being well are better if we continue pregnancy. The risk for the mother is too high. So terminate the pregnancy in the sense the child has to, the fetus has to not be, the woman has to not be pregnant for her to survive. The pulmonary hypertension is like a contraindication of pregnancy. So I think that's what they mean by termination. Regardless, I think you can just get it to viability. But even if not, when the mother's life is at risk, you have to just terminate pregnancy, any pregnancy.
Just to conclude, I think Dr. Lakshmi mentioned the fetus is viable, so they're terminating the pregnancy, which, like Sir said, is synonymous here with delivery, because baby would